over to her for a quick introduction as well as starting her presentation.
Thank you so much, Chrissy. So my name is Ecoee Rooney. I am a nurse. I'm a doctor of nursing practice. I work for Ochsner as well as for the Louisiana State Nurses Association, support them on their board. And I'm excited to talk about this topic of race and trauma today. My experience in nursing is both in education, but also as a forensic nurse. And so for the past 25 years, I have been deep in the work of understanding trauma and how it impacts people, not just acutely in the patients that we see, but really long-term, and understanding those pieces, especially as it relates to different intersectionalities, has been a big interest of mine probably for the last 15 years. And so let's get into it. So first, I just wanted to start by defining some different concepts, if you could. Yes, so racial trauma, or what is called racial-based or race-based traumatic stress, RBTS, is something that refers to the mental and emotional injury caused by different encounters of racial bias and ethnic discrimination that takes place continuously in many communities, as well as racism and hate crimes. And obviously, any person who's experienced these incidents knows that they're emotionally painful. They can be sudden and uncontrollable racist encounters. Anyone who is at risk for these is at risk for suffering a race-based traumatic stress injury. So in the US, we have Black, Indigenous people of color are most vulnerable due to all of the historical and systemic oppression that takes place in our systems. And for anyone who really denies this, so there's obviously a basic understanding that as we talk about this, that this is fact and this is real. And so as we have this discussion, this is the basic understanding or the premise upon which this discussion will take place. We know that experiences of race-based discrimination can have horrible effects on not just the people, but on their communities. And some people can even experience these incidents of racism so individually, because we know trauma is individual, that some people can actually develop symptoms like those experienced with post-traumatic stress disorder, that hypervigilance and all of that. Next slide, please. So when we really work to understand race-based traumatic stress, it can look like depression. It can look like having persistent, reoccurring thoughts of the incident. It can look like even physical reactions like headaches and stomach aches and chest pain, trouble sleeping. And even people can suffer low self-esteem depending on exactly what took place. And some or all of these symptoms can actually be present with someone with RBTS, but we know it looks different across different cultural groups and different individuals. But what's really important to know is that unlike PTSD, it's not a mental health disorder, it's an injury. And it can happen, as a result of living within our racist system or experiencing events of racism, either directly or indirectly. So for example, when George Floyd died in 2020, that was harmful to many communities just by witnessing it, by seeing it on television, but also understanding that this stuff happens all the time, that these things take place in our communities day in and day out. And so next slide, please. As we work to understand that, let's look just kind of at the historical overview of race relations in our own state. We know that in 1719, the first slave ships arrived from Africa, which was a year after New Orleans was founded. And then only 130 years later, there were 331,726 enslaved people in Louisiana. That was right before the Civil War. And then after the Civil War, there were, this period of Reconstruction, and there were racist mobs that within 50 years killed Black people during massacres in New Orleans, Thibodeau, Lucis, Colfax, St. Bernard Parish. So in those 50 years, almost 400 lynchings of Black people took place in Louisiana that are documented. And then we know, even as recently as 1953, Baton Rouge was the site of the first bus boycott, not the famous one that took place in Alabama that happened 2 years later, but we were very much at the hub of this movement in our state. And then in 1960, as you recall, Leona Tate, Tessie Provost, Gail Etienne, and Ruby Bridges became the four first Black girls to attend an all-white elementary school in the South, which was huge. And as we know and we understand now from the Brown versus Board of Education and all those decisions, the entire stressor was placed on those children, right? It wasn't, let's move faculty around, let's move teachers around so that there are Black teachers with Black children. They had to make the Black schools bad so that they could say, well, they're going to get a better education in this other environment, when in fact, the Black schools were doing phenomenally well. Children had high self-esteem. We're learning large amounts of information, and we're very smart and well-educated children. And so we recognize through all of the systemic oppression, how that really impacted and how all of the pressure was placed on the children, on the Black children, to make this happen, to make it okay. They were screamed at, yelled at, all of those things, and had to undergo a great deal of stress in that process. So just a few of these pieces of history can kind of give us an understanding of how much othering takes place and did take place, but still takes place in our state. And we see that in our outcomes, right? We see that in our health outcomes. And so next slide, please. We know that here in Louisiana, there are many inequities. As we look at incarceration, well, there you go. Per 1,000 Louisiana citizens, that you can see how great the disparity is in between white, Latino, and Black people being incarcerated. Same with percentage of Louisiana students without home internet. Although there's not such a huge difference as we saw in the first graph, there's still a difference, right? Latino and Black children are still not having the same access that white children in Louisiana do. And then the number of Louisiana students who are given out of school suspensions, that ties right back into our incarceration statistics, because as children who have maybe ADHD or problems learning or different discipline issues, they are started to be treated as bad. They're bad. Bad children are bad. And these children who end up believing that they're bad, end up moving in that direction. Their whole life trajectory shifts when they're not being respected, or they're not being heard. They're not being understood, or they're not being seen. And so we also know, of course, that Black women in Louisiana are 4 times as likely as white women to die from pregnancy-related complications, 4 times. And that our Black infant mortality rates are more than twice the rate of white Louisianians. So that's important for us to understand as well. All of these outcomes are very reflective of our greater systemic racism issues. So when we start to talk about understanding trauma, which is the next slide, trauma is really defined as the sudden, potential, deadly experience, often leaving a lasting, troubling memory. It's a very broad definition, and it can affect our beliefs about the future. When we experience a traumatic event, we may experience loss of hope. We may start to limit our expectations of life, like maybe I thought I could be this, but realizing after experiencing certain traumatic events, maybe I'll just always be this. Maybe I'll just be here. Maybe I won't get out of my neighborhood. Maybe I won't go to school or college as I had hoped. And then there's also just the fear of loss of life, like that I may not survive. If you look at young Black men and the sense of hopelessness that is pervasive in our communities in Louisiana, and a lot of young Latino men, Hispanic men here in our state, experience this fear that they are going to die, or really anticipate that normal life events like graduation or marriage or being a parent may never happen for them. Next slide, please. So some examples of historical trauma could include slavery and segregation and then desegregation, which was also equally traumatic, and discrimination that takes place all across the South. Then we know events like the Holocaust, like Katrina, environmental events like Ida, and the displacement of indigenous people across our entire country, all of those different historical traumas, and obviously mass genocides of people of color in all different contexts at different points in our history, really show us that this history of historical trauma then leads to traumatic stress reactions that include grief and other strong emotions, especially as we start to learn and understand each of our places in our history. And then, because of that, there may be an increased risk of substance abuse or dependence or suicidality or mental health issues because of this traumatic event, ongoing traumatic event, or maybe even just one event that was so overwhelming. And then we know that because of that, we have an increased risk of experiencing other traumas like accidents and violence and physical and sexual abuse because of our vulnerability from that space. So next slide, please. I want to dip into the conversation about adverse childhood experiences because that is a whole other realm of trauma that I think we need to address and understand. We know that some of those adverse childhood experiences can include issues of mental health in the home. So someone who has a mental illness or a mental health crisis that maybe lasts is more chronic. Emotional or sexual abuse, those are two others. Substance abuse in the family, so in the household that people are drinking too much or using drugs in front of children. There's domestic violence, physical, emotion, and or emotional neglect of children. So not knowing where my next meal is coming from, not having enough food, not having, and you can see how some of these neglects may not be intentional, right? Because of resources or a lack thereof. Then divorce is another one of the adverse childhood experiences, incarceration and homelessness. All of these different types of experiences are those, they say, that are experienced before the age of 18. So if those are experienced before the age of 18, they're considered adverse childhood experiences. And so some other adverse community events that really impact these experiences can be poverty, deep poverty. We know that 50% of Black people in Louisiana live in deep poverty, 50%. Discrimination, community disruption, lack of opportunity or economic mobility or social capital, having the power to do something, to change something, poor housing quality, affordability, and of course, violence. Next slide, please. So when we look at the data on ACEs by race, there's also a disparity there. We don't have any Louisiana data on the prevalence of ACEs and especially the breakdown by race. However, we know that the ACEs study, which took place in 1999, which actually identified the 10 ACEs, and then the relationship between ACEs and the impact on our adult health was landmark work that took place and I think really needs to be understood better. But as you can see, the difference between white children who experience ACEs, maybe at 40% to over 60% of Black children that experience ACEs, and then Latinos, a little bit above 50% of them experience ACEs. So that's important because when we start to try to understand what ACEs do to our folks throughout their life, next slide, please, we can see that those adverse childhood experiences lead to disrupted neurodevelopment of the child because of that constant dump of cortisol and that feeling of anxiety that children carry with them, that fear of, am I going to get what I need? Am I going to be abused again? Am I safe? to go home. That constant dump of cortisol and other stress hormones really creates a shift in the neurodevelopment of that person, the way they react to things, the way they respond to things, the choices they make about their lives, about their health. And so those social, emotional, and cognitive functions become impaired somehow. And then there's an adoption of health risk behaviors and disease, disability, and social problems and early death. So when we really go back down into this and start to understand those different levels, this is really talking about people who have 4 or more ACEs. We know that most people have 1 or 2 ACEs, right? Many people have divorced parents, or many people have parents who were drinkers, or, you know, there might be different pieces of this, but when you start to have 4 or more, that was the number that they saw. It was like 4, then it was very easy to go to 5 to 6 to 7 to 8 to 9 to 10. You can see that because of the social context, because of the other things that might be happening, different comorbidities going on together. And so the good news is that now in recent years, there has been something identified as PACEs. I had seen this myself with my patient that I took care of. When there was someone, one person, it could have been a grandmother, it could have been a teacher, a coach, someone who really saw that kid and supported them. They were a go-to person. They were a safe person for them. That very quickly starts to shift the trajectory of that person's life. So these PACEs, these different kind of preventive measures of ACEs, of the long-term impact of ACEs, are, like I said, a solid relationship, or even just one person. Resources. So suddenly they are resourced. They go to school and they get a backpack and they get uniforms and they get a jacket. I know a friend of mine who's a school teacher told me she gave a kid a brand new backpack full of all of the things he needed for school. And when he went through it, he was like, my own pencil. I have my own pencil. And then he got a brand new jacket, and then he got a brand new shirt for school, like the uniform shirt. And he said, I can take off this jacket now because it's so hot, because I can wear this shirt because it fits me. And when he took off his jacket, she could see his shirt was kind of, you know, halfway up his chest. It didn't cover his belly. And she recognized, you know, how important just resources are to that person for their self-esteem, their ability to see themselves succeed. Like, if this good thing happened, well, then maybe another good thing could happen. Protective and compensatory experiences, maybe therapeutic communication. Someone tells them, you know, what's happening to you is absolutely not okay. To hear that from an adult when all they know is bad things, to hear that from an adult outside of their household, they say, oh, wait a minute, their paradigm starts to shift. You mean this isn't happening in every household? Every child isn't treated like this? And so having that support for social, emotional, and cognitive functioning, learning, and being supported with cognitive behavioral techniques, healthy behaviors, they then start to learn, and they begin to achieve those developmental milestones. Even if they're delayed, they start to quickly advance and achieve more successes. And then, of course, this then impacts their overall health and longevity. Next slide, please. So when we look at some other factors of trauma, we need to understand as well intergenerational trauma and what's called epigenetics. And I'm not sure if you are familiar with epigenetics or not, but basically what the research has shown is that mothers who are exposed, this was the first day, who were exposed to the Holocaust, actually showed changes in the activity of a DNA segment that's involved in regulating the stress response. When they found that in these Holocaust survivors, then they started to recognize exponentially all of the different ways that this can be understood. So those women's children who were not directly exposed to the Holocaust also showed these same changes in their DNA. And with intergenerational trauma, we know that depression is 1.7 times higher, that chronic depression is 2.5 times higher in children of women who've experienced severe child abuse compared with children of mothers who didn't experience such abuse. So that may sound like, oh my gosh, I'm passing down trauma to my children talking about. Well, just remember the paces, right? You are a loving parent. You are a compassionate parent. So these things need to be understood as well for all of the things that help us survive and thrive. Next slide. I want to also talk about intersectionality and trauma. I think it's important for us to understand that Black, Indigenous, people of color can intersect with other identities, right? So I may not just identify as the BIPOC, but have a different gender identity. I may be trans, I may be gay or lesbian, I may have a disability, or my housing status is insecure, or my socioeconomic status is insecure. And those different pieces of intersectionality, obviously, you can see kind of layered onto the initial factors can really create more and more unique challenges for the people at these intersections where they have multiple marginalized identities, and then they experience further isolation, further vulnerability, and exclusion, not just from maybe mainstream society, but exclusion from opportunities for health and well-being, for screenings, for going to the doctor, because many people just say, oh no, I am never going back to healthcare because of the way I've been treated. No way. Next slide, please. So what can we do? I think that looking at what the CDC has said about preventing adverse child experiences, I think that every single one of us who cares for and provides services to people here in Louisiana, we can intervene to lessen immediate and long-term harms. And you may not realize that's what you're doing, but your job may already be that. You may already be doing that every single day and just not recognizing the tremendous impact that you may be having on a patient. So some of the things that we can do is enhance our primary care services, very much like what we were talking about, even those screening services with the civil surgeons. And what an amazing thing to understand that we could seek to understand better so that maybe we can improve the system for people. Victim-centered services. So in other words, providing people in a trauma-informed manner. In other words, understanding that anything that we're trying to do for that person is going to be done in a way to avoid re-traumatization. Treatment to lessen the harms of their ACEs. So if there are things that are outstanding symptoms that we can address, and then therapeutic involvement as well. Treatment to prevent problem behaviors and future involvement in violence. We have so many model programs. I know the reconciliation programs that exist in New Orleans have been very successful at looking at how to prevent further harm, how to prevent retaliation. And then family-centered treatment for substance abuse disorders, which is super important as well. Next slide, please. When we look at Carl Rogers, who was a psychologist, this concept of unconditional positive regard is one that I really believe is central to every single one of our missions, right? According to Rogers, that unhealthy behaviors like overeating and drinking too much and smoking and not adhering to medication regimens aren't going to be altered with confronting people and judging them and punishing them. In other words, I'm sure that you know people just like I do who say, oh, I'm not going to the doctor till I lose 15 more pounds because I don't want to hear about it. Or, I'm not taking care of myself. And so I really want to avoid going back to the doctor, because those painful experiences of being bullied and shamed or judged is going to thwart our growth. And we know that according to Rogers, we are hardwired for self-actualization, right? When you look at like the Maslow's hierarchy of needs, we are hardwired to self-actualize, to become our very best selves, to fulfill our ultimate potential. But all of these different experiences can bring us back down. So unconditional positive regard for someone really restores hope by showing us that I'm loved, I'm accepted by you. You're not judging me. I'm telling you all of these things. I'm telling you about my lifestyle, and you're not flinching, and you're smiling and nodding. Wow, this is different for me. And when people feel safe, then honesty follows. And honesty is what is crucial for them to grow and change, to be able to improve those behaviors. And so I want to end by just thanking you for your time. I was sharing with you a couple of resources that may help you learn more. If you have other resources, I encourage you to share them with Chrissy if there's something that I didn't, but I wanted to just give you a few. The last one is really about an initiative to map disparities in chronic disease. And that is where I think Louisiana really needs to head, in the direction of being able to, like they say here, see the maps and close the gaps. And so when we can see where, you know, people are and where these issues are happening, then we can aim our resources there. This is my reference list on the next slide. And my final slide is just my huge gratitude. Thank you for being the change. And I think we're just about at time, but thank you so much for being here today. Any questions?